this is going to be more of it's a pretty broad topic of structural heart disease or valve disease, so I'm kind of glossing over some things, trying to just cover as much as possible. So I'm happy to be interrupted with questions, or if anybody wants to hear more about any of these, we can delve into it. So just as a, this is our typical valve patient. I don't know if you know this guy, but he did pretty well after his transcatheter aortic valve replacement. So I think this is a disease that is kind of broadly reaching, and a lot of different pathologies to cover. I'm going to kind of just go by valve: aortic, mitral, tricuspid. I'm leaving the pulmonary valve out, and then we'll talk kind of about how we approach disease at the University of Utah. So for the aortic valve, this is really where obviously a revolution has happened in the last 10 years with all the transcatheter therapies and transcatheter valve replacement. I wanted to kind of start with a patient story. So this is a patient of mine who is a 52-year-old. He's actually a triathlete, and he came to me after presenting to his primary care physician with just a little bit of shortness of breath, and his times were starting to slip, his races. And he said, something's wrong, I'm not doing as well. He'd known he'd had a murmur since childhood, hadn't really been worked up, really no other medical problems, wasn't on any medication. They got an echo, and he had severe aortic stenosis and a bicuspid aortic valve. So came to me as a very informed, inquisitive patient, asking about what's this transcatheter business, what do we need to do? He was adamant that he didn't want to have Coumadin. He wouldn't even let me get started on the mechanical valve spiel, and he wanted to hear about, I want the fewest procedures possible, and I want to get this fixed and get back to racing. So what are his options? So we kind of worked him up. He was low risk for surgical valve replacement, but we had the low risk TAVR trial available when he came to see me. And so we talked about that as an option. This is a CT scan, and I put this in here to show, this is pretty typical for bicuspid valve patients, that the annulus there is not really a circle, it's an oval, and that's pretty typical for bicuspid patients. So he and I had a long chat about what that means for potential paravalvular leak with transcatheter replacement, and what that means for longevity of his procedure. And we ultimately went back and forth, and he decided to go with surgical valve replacement. So we ended up doing a mini sternotomy. This is actually not him, but very similar patient to him. And we put in one of these newer expandable prostheses, which can hopefully facilitate future valve in valve. He did great. He was in the hospital for 5 days, pretty much back to full function at 6 weeks. And now I just saw him a few months ago, and he's back to triathlons and doing great. So this is kind of it's almost a historical kind of patient, because this surgical pathway is now kind of coming into question. And I think I wanted to highlight this as, yes, we do surgical valve replacement for the aortic valve, and these patients can do well, but this may not be the way to treat most people. Wasn't sure who would be in the audience, maybe some medical students, just to throw this in there. I like this because the aortic valve's in the middle. This is the center of the heart, which is not always something that we think about unless you're staring at the aortic root a lot, but I think the aortic valve is central to everything. Aortic stenosis, you all know, is a progressive disease. It's getting more common as the population ages. This is a more and more common disease. 1 or 2% of the population above 65 is going to have some calcific aortic disease. So this is a huge clinical problem. Bicuspid valve disease is a kind of related pathology. 1 to 2% of the population is born with the bicuspid valve. And we talked a little bit about this last year when we were talking more aortic disease, but this is very relevant for valvular dysfunction, kind of independent of aortic disease. And there's that last point there. There's no medical or lifestyle cures for AS, as you know. So you can't go on the keto diet. You can't take medication. This is something that has to be fixed structurally. So for years and years, the surgical aortic valve replacement is the gold standard. You all know this. If you leave AS alone, these patients do not do well. If you replace the valve, people do well. So this is a very fixable problem, and it's now been revolutionized by transcatheter. So TAVR, as I'm sure everyone in the room is aware, is a transcatheter aortic valve replacement. So this is endovascular through usually the groin artery up into the heart, and these are the two main valves of the SAPIEN 3 and the Evolute, which is the Medtronic valve. This is a kind of newer one, the Lotus, that we're going to start using at our center just to try to have different options for different patients. But this is a dominant technology, and it has rapidly gained kind of acceptance, and is now becoming, I think, the standard of care for aortic valve disease or aortic stenosis. So this is I'm not going to have too much data in this talk, but this is an important one. So the PARTNER 3 trial, which was the Edwards valve, the SAPIEN valve trial, just published the 1-year data in the New England Journal. This is a mean age 73. These are all AS patients, low risk for surgical aortic valve replacement. So these are otherwise healthy patients, and TAVR did great. These patients did very well, both mortality, stroke, combined endpoints, all favored TAVR over surgical aortic valve replacement. So this is, I think, in this patient population, the gold standard for aortic stenosis is going to be transcatheter aortic valve replacement. But there is a but. There are some exclusion criteria for these, both the PARTNER trial and the CERTAVI and the Medtronic major trials, is that there were no bicuspid valve patients involved in those. Those were excluded. There's no aortic insufficiency. This is all AS. And then there's no other conditions, so no chronic heart failure, like Stavros was talking about, and no complex coronary disease, and no obese patients with a BMI over 50. And so the patients that were not included in the PARTNER trial are actually a fair component of patients that we all see with aortic valve disease and aortic stenosis. So I think TAVR is the new gold standard for aortic stenosis, but not for every patient. I think there's still a role for surgical valve replacement. I think we'll talk more about the kind of heart team approach later, but I think this is really something to keep in mind. That being said, we've all kind of had questions.
Attention, Carson Papa. We will still be giving out flu shots in the Bristol code across cafeteria.
Durability of TAVR valves.
Volunteers and
it's hard to compete with that. One more time.
Repeat. Flu shots in the Bristol code across the hall from the cafeteria until 7 p.m. for staff, volunteers, family, and visitors.
All right. So these are data looking at, this is actually the PARTNER 1 cohort. So these are the high-risk patients that got TAVR 6 and 8, 10 years ago. And this is looking at echo at 5 years out from implant. And this is kind of a busy slide. It's hard to see, but this is the mean gradient here. We see it's stable at around 10 or so at 5 years. And then this is the LV remodeling that Stavros was talking about. So LV hypertrophy at implant, and then it gets better, and then that's persistent at 5 years. So at least the early data that's coming out, the TAVR valves do appear to be durable. This, I didn't put it up here, but this is basically identical to the surgical arm of this trial. So at least at 5, 8 years, now there's some 8 and 10-year data coming out of Europe that look the same. So I think the TAVR durability is going to be less of a concern than we all thought maybe it would be. And so I think the kind of bottom line for this is that TAVR is here to stay. Another thing that's important to talk about is valve-in-valve TAVR. So patients who've had a prior surgical valve replacement or possibly prior TAVR are candidates for this valve-in-valve technology. So on top, that's a SAPIEN valve inside of a Magna Ease surgical valve, and then the Evolute valve at the bottom. So this is a very viable strategy for patients who've had a surgical valve and that valve wears out, which we know they do at 10, 12, 15 years. We can now do a valve-in-valve to prevent another reoperative sternotomy in these patients. And then this third point, I think, is something that we're starting to really have to get our hands around as a community, as a practice, as a specialty in all cardiovascular disease management, is how do you manage or how do you plan longitudinally over the life of a patient? So it used to be that you had surgical valve replacement, and then if you needed another one, you got another surgery and another surgery. But now we can start, that 50-year-old that I presented with the bicuspid valve, we can start to talk longitudinally. Do you do the TAVR first, and then a valve-in-valve TAVR, and then maybe surgery later, or do you do surgery first and then a TAVR, or some combination of those things? And it used to be that in a young patient who needed a surgical valve replacement, they got a mechanical valve, and that was kind of the best option. Now, with this kind of approach, we're starting to move away from mechanical valves because a lot of patients don't want to take Coumadin for understandable reasons. I wouldn't either. But this brings up a whole host of discussions that we're now having as a team with our patients about what are we going to look at the next 40 years of your valve disease management. Another thing I wanted to mention that we're doing is this procedure called balloon valve fracture, BVF, when patients who have a smaller surgical valve, and if we put another TAVR valve inside of it, you start to worry about patient prosthesis mismatch, where the effective orifice area of the valve is too small for that patient's body size, and you're essentially giving them aortic stenosis by putting in too small of a valve. So this is a technique that's been developed, which is on first pass completely terrifying, but actually does work. It's using a non-compliant, very stiff balloon to actually fracture that surgical valve frame when you put in the next TAVR valve, when you put in the valve and valve TAVR. We've been doing this. We've done about 20 or so patients with very good success, and it's kind of a nerve-wracking thing because you see the balloon kind of waste, and then it actually, with an audible pop, will break these valves, but it allows you to get a larger TAVR valve in, and it extends that longevity for the patients and potentially avoids reocular surgery. So this is something that is in use right now, and I think over the next couple of decades we're going to be kind of maturing these clinical paradigms and trying to figure out how best to manage these patients. That patient I mentioned earlier has one of the newer valves that actually has a design feature in the frame of the valve that's designed to expand. So it's not a single ring of metal. It actually has joints that will expand and facilitate this. So the technology is innovating along with our clinical paradigms as they evolve. So I think the future is now with aortic stenosis. Transcatheter valve therapy, TAVR, is first line for AS, I think. I'm pretty comfortable saying that as a surgeon. I think that this is here to stay, and it's a great therapy. These patients do these not under general anesthesia, but under MAC, so the patients are awake and talking to us. We had one the other day where the guy was just chatting the whole time, telling jokes literally while we were putting his valve in, which is a little bit odd, but it's an incredible change. And they go home within 24, 48 hours. And so I think, hands down, it's a great therapy. We're blurring the lines of our specialties. So we work together with, I'm a surgeon, but I work with the interventional cardiologists, and they're learning to think like us, and we're learning to think like them, and the lines are blurring, and it's now just becoming a cardiovascular team, a structural heart team, rather than a surgeon doing things their way and an interventionalist doing things their way. This is really an exciting time to be doing these things together. And so just also wanted to mention alternative access, because one of the things that we are doing at our center, and I think one of our roles as kind of a tertiary care place, is to expand the options for TAVR. I think the vast majority of people can get transfemoral, which is definitely the first line preferred way to do TAVR, but if someone has peripheral vascular disease, their femoral are small or stenotic and it's not safe, we go to other sites. And we've done transaxillary, both open and percutaneous approach, direct aortic approach, transapical, which is a thoracotomy in the chest. And lately, what is now rapidly becoming our preferred method is this suprasternal approach, which is a very small incision here in the neck. You can barely see it. It's very similar to a mediastinoscopy that people get for lung cancer staging. And we actually have a surgical exposure of the innominate artery, and then we do the TAVR through the innominate artery. And it actually works really well. And the morbidity from this incision is much lower than a transapical for sure, and even a transaxillary or direct aortic. So there's a lot of options for getting these TAVR procedures accomplished, and we are kind of aggressively pursuing all of these different techniques. And I think that it's, the next few years are going to be even more exciting as we continue to mature these different ways to do it. And then the longitudinal procedural planning is I think, really important. Going back to that case that I presented, I think for the bicuspid patients who are going to come earlier in life, they're going to be younger, they're going to be active, they're going to be low risk. And a lot of those, the annulus for a bicuspid patient often is that oval shape that I showed in that CT scan. And a lot of times they'll have kind of uneven calcium, where one cusp is very calcified and the other one's not so much. And so you can visualize when the TAVR goes in, that none of that calcium or leaflets are removed. And so if it's uneven calcium, then the risk of leak and long-term performance issues is more of a concern. And so I think one of the things that we talk about with our bicuspid patients who are younger is that it may be prudent to do a surgical valve first, which then we debride and remove all that calcium and make that ovoid annulus into a circle with one of these new valves that can expand later, and then that kind of sets up a platform for lifetime valve and valve TAVR. And so this is something that we are, really trying to figure out as a field, and there's no data to guide this yet, but we're going to try to, be as thoughtful as we can with each patient. And I think that there's still a role for surgical valve replacement as the first intervention, and especially a young patient. And this is a conversation we have with with all of our patients. And we've had some that say, I don't want surgery no matter what, you're not opening my sternum, and we'll do a TAVR valve in a bicuspid patients. And other patients that we talk through this and say, well, you know, in the next 30, 40 years, do you want to risk another sternotomy, or do you want to set yourself up for valve and valve TAVR? And so this is something that the nuances that we discuss with our patients, and that everyone here that takes care of these patients can start to have these conversations with people, because now there are options. One last pathology to talk about is aortic insufficiency, which is kind of a whole different animal than aortic stenosis. It's a much more nuanced clinical presentation. There's a lot more that goes into it. Calcific aortic stenosis is relatively standardized. It's very kind of consistent across patients, especially with the tricuspid valve. Start to get into this algorithm. It's a little bit nuanced. It's a little bit, and I think that aortic insufficiency over the years has been intervened fairly late. I think that all the guidelines wait for either symptoms or LV dilation or LV dysfunction. I think that people are starting to reconsider that, and I think that we as a field could be more aggressive in intervening with aortic insufficiency, because the patients will definitely do better if you intervene before the LV dilates and before the LV fails. And then also it comes with all these other things. So there's a lot of aortic root pathology that goes into aortic insufficiency. So patients who have dilated annulus, this ANNULOAORTIC ectasia, which can be associated with connective tissue disorders like Marfan, et cetera, but also can be bicuspid valves. And then this is something that we see a lot of, where patients have a bicuspid valve, the root's a little bit big, there's not a frank aneurysm, but things look a little bit more on the ANNULOAORTIC ectasia spectrum rather than the bicuspid stenosis spectrum. And I think that there's some data that shows that those are more towards the genetic aortopathy spectrum patients rather than the kind of traditional AS patients. And I think those patients still should be considered for open surgical repair, especially if they're younger, because I think it's going to be a more durable result. I think putting TAVR valves in patients with dilated roots or pure AI is, although sometimes possible depending on how big the annulus is, I think should be approached with significant caution before we go down that road. And then there's some evidence, and there's a role for surgical valve repair. So a bicuspid patient with an enlarged root, but a relatively functional valve with some central aortic insufficiency, those patients can be repaired. And we're doing surgical valve repair, valve sparing procedures, valve sparing root replacements on patients with bicuspid valves. You have to select them carefully because they're at higher risk for recurrent AI down the road. But this is data from Tyrone David's group that shows for tricuspid and bicuspid patients excellent results in properly selected patients. So this is the kind of the full spectrum. I'll pause here for a second because I'm going to move to mitral. But any questions or comments about the kind of aortic disease work? We'll do that pretty quickly. Any patients that come with TAVR questions, or I think TAVR is so now, if you Google aortic valve, you get more TAVR information than you can deal with. Is this something that we find that our patients come to us very educated on TAVR? Is this something that everyone is expecting now in your world, dude?
I'd say most of them are, definitely asking the questions.
Yeah.
Especially if they've been following their valve for a long time and talking about the different options.
Right. Yeah.
A couple of years ago, it was sort of less asked, but now I think pretty much everybody has a question about it.
Right. Yeah. And I think it's appropriate. I think we should at least consider TAVR in every patient with aortic valve disease. And a lot of them, like we said, may or may not be good candidates, but it should be part of the conversation, I think, in everybody. So, and it's exciting to be able to offer this to patients. Yeah.
How often are you seeing, or do you see an uptick in AV block and TAVR versus surgical valve?
Yeah, it's a great question. I think that the earlier TAVR trials, it was definitely worse. I mean, the original PARTNER 1, it was 12-15%, I believe, and the core valve was even higher. Each round of technology has gotten better with TAVR. The pacemaker rate in the PARTNER 3 data, the pacemaker percentage was 2%, which is now about the same as surgical valves. So I think that as the technology improved and as the procedural understanding matured, that the pacemaker risk with TAVR is now much less than it was before. I think it's still an issue, and we still counsel all our patients about it, but it's definitely better now than it was in the first generation.
For patients with connective tissue disease, you say you're using this in younger populations. What's the youngest you've gone for?
Yeah. So we have done a few patients in their 50s with bicuspid valve disease and kind of pure aortic stenosis. I think in patients, certainly patients with Marfan disease or Ehlers-Danlos, one of those true connective tissue aortopathy, those are not appropriate for TAVR unless they've had a prior root replacement and you're doing valve and valve. So the bicuspids, I think, are in the middle. I think a bicuspid patient with pure aortic insufficiency gives me pause because I think those patients are much more likely to have a true aortopathy and they're at risk for further dilation of their annulus down the road. I think a bicuspid patient with aortic stenosis is probably safe for TAVR, given those things we talked about the oval annulus and those things. But anyone with AI, I think, should be a red flag that this may be a connective tissue spectrum aortopathy patient that should give us pause before we just put a TAVR valve in, because the risk of a long-term annular dilation in those patients is real, I think, especially if they're younger. So.
Can the valve and valve replacement be done on patients with mechanical valves and tissue valves, or just one of the others?
That's a good question, and we get that a lot from patients. And as of now, there's no way to do it on a mechanical valve because the way the TAVR crushes everything away, you can't do that with the metal. So I think there may be a role for some percutaneous or endovascular things with certain modes of failure with mechanical valves, like paravalvular leak, for example. If you can plug some holes, but that in terms of TAVR valve and valve, it's only for tissue valves. Yeah.
Do you hear any degree of murmur after it's in place?
Yeah, that's a great question. It depends a lot on the relative size of the TAVR valve or the surgical valve to the patient. So a patient that has a mean gradient of 9 or 10, like we saw in those data, and that has a well-functioning valve, the murmur should be minimal. I mean, you probably will hear a little bit of a murmur. Almost all of them have something, but if you have a significant murmur after a TAVR or a surgical valve, then you have to worry that the gradient is increased. I didn't mention it, but one of the Achilles heels of all valve replacement is early thrombosis. And so our protocol for TAVR is 6 months of dual antiplatelets, so Plavix and aspirin. And for surgical valves, we typically use Coumadin for 3 to 6 months to prevent this early thrombosis. So if you see a patient who's relatively early, meaning within the first year or two after a valve replacement, and they have a murmur or they have an elevated gradient on the echo, then that most likely is due to thrombosis, and those patients should be treated with Coumadin, and they actually can get better. And so that's something to watch out for. So a little murmur, 1 or 2 out of 6 is expected. 3 or 4 out of 6 murmur in a recent valve replacement patient should raise a red flag for acute valve thrombosis, and they should get a CT scan to look at that or a dedicated echo, and probably should be treated with 3 to 6 months of Coumadin to try to get that. And you'll see the gradients can actually get better after that period of Coumadin when the valve thrombosis is treated. All right, well, let's move on to go to the mitral space. So another patient story to tell you about, a patient we had who was 62. She was obese. She had kind of mild to moderate COPD, was not on oxygen, but had some pulmonary disease. History of rheumatic valve disease with her aortic and mitral, as well as coronary disease. She'd actually seen in another facility 4 years ago, and had an aortic valve replacement and a coronary bypass grafting surgery done. The surgeon at that time had planned to replace her mitral because of her mitral stenosis, but he took one look at the mitral valve, saw horrible mitral annular calcification, and he aborted the mitral, said, this is not going to work. This heart's going to fall apart if I replace the mitral, and so he left the mitral alone. She did okay for a couple of years, but then had persistent shortness of breath, persistent symptoms, came to us, and her echo showed, as expected, severe mitral annular calcification and severe MS. Her aortic valve was fine, her cabbage grafts were open, and she's had a sternotomy, she's obese, she has lung disease, so she's relatively high risk for a reoperative sternotomy. And she was very adamant that she had a tough recovery from her first heart surgery, did not want to go through that again, and so came to us asking for other options. This is her CT scan, so you can see that's the mitral annulus there with the bright, dense calcium circumferentially around the annulus. This is her native mitral valve. severe mitral annular calcification, severe rheumatic mitral stenosis, prior sternotomy. What are her options? So we ended up doing a transapical TMVR, so transcatheter mitral valve replacement through a left thoracotomy. And this, basically, you see the transcatheter mitral as the sapien valve in the mitral position next to her perimount surgical aortic valve replacement. She did very well. She had a relatively uneventful postoperative course, hospital in 4 days, feeling much better, and we just saw her a few months ago, and she's doing great. So this is a little bit of an out-of-the-box, kind of off-label approach to mitral valve disease, but this, any surgeon will tell you this is what keeps us up at night, trying to deal with the severe mitral annular calcification in the operating room, because as soon as you start trying to debride that, the posterior wall of the ventricle and the AV groove is very fragile, and these are devastating complications when you get that posterior disruption and atrioventricular dehiscence, and that's this approach can avoid that complication. So that is backdrop in another anatomy slide for the medical students or other students in the room. The mitral valve, in contrast to the aortic valve, is very complex, very dynamic structure. The aortic valve has a fibrous annulus, it's relatively circular, it's relatively consistent across patients. The mitral valve is quite variable, as you all know. We take care of these patients and look at echoes. So it's a much more complex kind of valve to deal with when it's not working well. So this is just some kind of cartoons from the various surgical valve techniques, and this is the anterior leaflet, posterior leaflet. These are posterior leaflet resections for mitral valve prolapse and mitral valve regurgitation. This is just to show that there's a lot of different techniques, and this has been the last 30, 40 years. Surgeons have been delving into the weeds with various surgical and mitral valve techniques, and this is actually a very mature field. This is a picture of the mitral valve calcification that I mentioned. So this is debriding the mitral calcification. This represents the back wall of the heart, which is very, very thin, and once you take that mitral calcification out. So these are more data from Dr. David up in Toronto, one of the kind of experts in cardiac surgery. This is 20-year results for surgical mitral valve repair, and the results are outstanding. The durability of the repair, sorry, can't be trusted with this thing. The yellow line is event-free survival, so that's 60% at 20 years, and the mean age of these patients was 60 years or 59 years old, so that's pretty impressive results. Very low valve reintervention rate, very low cardiac death rates. So this is really the gold standard for surgical repair or any kind of structural repair of mitral regurgitation. This is another study looking at minimally invasive mitral repair, which is through these small thoracotomy incisions. And these are also, it's kind of small here, I apologize, but this basically very durable results. So mitral valve surgery is very mature and very good results. This is more from Dr. David. The point of this slide is to show that there are some patients who do worse with surgery, and really the kind of going back to what Stavros was talking about, the ventricular function, ventricular performance is the most important predictive factor for how someone will do following mitral valve repair. So surgical mitral valve repair, in the top left, that purple is class 4 NYHA heart failure versus the blue, which is class 1. And so if you come into mitral valve surgery with a failing ventricle, not that surprising, you'll do worse long term. So while mitral valve surgical repair is outstanding, there is a subset of patients that will not do great with mitral surgical repair. And so that is a space where people have started to move into other ideas. And so now we have MITRACLIP, which I'm sure everyone in the room has at least heard of. The concept for this is actually the endovascular or transcatheter-based application of a surgical technique. So Dr. Alfieri from Italy developed this edge-to-edge repair down in the bottom left. So this is a surgical repair where to treat mitral regurgitation, you just take a suture and you tie the leaflets together, which doesn't eliminate the mitral regurgitation, but it can minimize it. And for a patient who has high surgical risk or has other complicated anatomy that a more complete repair is not possible, this is a technique that's an adjunct for surgical repair. And so people took this concept and applied it to a transcatheter device. So this is the MITRACLIP device. It has two wings to it that will actually grasp each leaflet, the anterior and posterior leaflet, underneath under transesophageal echo guidance. And then when that clip is deployed, it brings the two leaflets together and replicates that surgical repair. So instead of a suture, it's a clip on the mitral leaflets. And this is done from a transseptal approach. So you go up the femoral vein, across the atrial septum with a special technique, and then deploy this clip in the cath lab. So this is an endovascular transcatheter therapy trying to replicate surgical technique, and actually has in certain patients has performed very well. And I think that the first application of this was for degenerative valve disease patients, so prolapse patients with MR who are not surgical candidates or high risk for surgery for whatever reason. This can take the mitral regurgitation from severe down to mild or moderate and save the patient the morbidity of surgical repair. Probably everyone's heard of these two trials. This is MITRACLIP in heart failure patients. And so the COAPT trial was a US trial, and the MITRA-FR trial were done in Europe. These are patients who had near end stage heart failure with severe mitral regurgitation who were randomized to optimal medical therapy alone or therapy plus the MITRACLIP procedure. And this is the COAPT data. The red is this is hospitalization for heart failure and death from any cause. The red is the control group or the optimal medical therapy group, and the blue is the MITRACLIP plus medical therapy. And in terms of readmissions for heart failure and death from all-cause mortality, the MITRACLIP performed better in the COAPT trial. Interestingly enough, in the MITRA-FR trial, the same primary outpoints, there were no difference. And so what to make of these two kind of seemingly conflicting trials? And I won't delve into more than to say that kind of if you look at the patient cohorts, the COAPT trial excluded the dilated ventricles, so LV and diastolic dimension greater than 7 centimeters was excluded from the COAPT, but included in the MITRA-FR trial. And so what you get is this kind of matrix down here where you have severe MR, but a burned out ventricle will not benefit from MITRACLIP. Those patients, like Stavros was saying, if you intervene too late, those ventricles are too far gone. They're burned out. They're not going to recover. So severely dilated ventricle not appropriate for MITRACLIP in heart failure therapy. Those patients should be probably more down the advanced heart failure pathway that we just heard about. Patients who have some ventricular reserve or they're not completely dilated, but they have reduced ejection fraction and severe MR, those patients, more like the COAPT trial, those patients did benefit from MITRACLIP. So I think that MITRACLIP is going to have a role in heart failure with careful patient selection. And we're starting to see more of that in our program, and we're starting to figure out as a team, both the failure team and the structural heart team, working together to try to choose which patients we're going to use this on and which patients might benefit. I mentioned earlier the mitral annular calcification, which is a huge problem for us as surgeons. And so one potential solution is what that patient that I mentioned had, which is a transcatheter mitral valve replacement in native MAC, in mitral annular calcification. If the calcification is not circumferential around the mitral annulus, we think it's not safe to do a true transcatheter mitral. So we've developed this hybrid approach where we do an open surgical exposure of the valve, and this is for mitral stenosis, and put the patient on the heart-lung machine, open the heart, open the left atrium. But instead of excising the calcium and trying to sew in a surgical valve with sutures, we do a direct deployment of a sapien valve, which is what we're showing here. So that's direct vision deployment of a transcatheter valve without excising any of that calcium. So the valve is seated in the calcium, and then we can look and see if there's any points that are loose or leaking. We put a couple sutures to kind of tack it down, but we do not excise any of the calcium. And this is a relatively kind of niche procedure that, so we haven't done a lot of these, but in that patient who has rheumatic stenosis with a ton of calcium, but it's not circumferential, this is a great technique for addressing that problem while minimizing the operative morbidity of trying to excise all that calcium, especially in the posterior annulus. And then the final thing to mention with transcatheter is the valve-in-valve option, and that's similar to the aortic valve that we talked about before. If someone who's had a prior surgical valve in the mitral position valve with the transcatheter, and it's been the balloon expandable, the sapient valve that is the only one that works here. And we've had good success with that, and that's a true transseptal or transcatheter procedure. So we're starting to see in the mitral world that there are some options that are not traditional open surgery, although it's a much more complex space. And so while TMVR is a good solution for bioprosthetic valve, TMVR for native MS is tricky. And I would say that should be done in a very kind of careful way, because I think if you have not enough calcium to seat that valve, your risk of embolizing the valve is pretty significant. So I would say that surgical valve repair remains the gold standard for mitral valve prolapse with mitral regurgitation. I think that these transcatheter therapies are going to have a role, but it's not going to be the same paradigm as TAVR and aortic valve disease. This is not going to take over mitral valve and kind of eliminate surgical mitral valve repair. I just don't see that happening. So MITRACLIP for inoperable structural degenerative patients with MR and prolapse, MITRACLIP for a subset of failure patients, but surgical resection or surgical repair is not going away. And this is just a picture of the robot. We have not embraced the robotic mitral at our center, but there are some centers that are doing it. So minimally invasive techniques, robotic mitral repair, all that stuff I think is going to be still relevant in the modern era of mitral disease management. So before we go on to tricuspid, we'll pause. And any comments or questions about mitral pathology? How about MITRACLIP? Is that on people's mind? Is that coming up in your conversations with your patients? It's probably not as much as TAVR. Yeah. I think when the COAP data came out, there was this kind of brief exuberance about, well, now we can do this on all heart failure patients. But then the MITRA-FR data came out and said, okay, wait a minute, this is more complicated than originally thought. And so I think this is very much in its infancy, the MITRACLIP in failure, but I think it's going to have a role. Probably not going to be all comers, certainly not going to be kind of one size fits all the way that TAVR has been for aortic stenosis. Go ahead.
I wasn't going to interrupt. I'll ask after you're done.
Okay. I was just going to say, one caveat to the mitral surgical repair is that, as with many surgical procedures, especially more complex things, patients do better and the outcomes are better at centers that do a lot of these. So it's one kind of role for surgical expertise in mitral valve surgery is absolutely a difference in terms of outcomes and risk for patients. So I think that at least having the conversation of where the patient's going to get surgery is relevant and important to think about. Go ahead, sorry.
So my thinking is, why can you do this with an aortic valve, with the TAVR, but you can't replicate that with the mitral valve? It's the technology would be adaptable. So
it's a great question, and I think a lot of it has to do with the pathology that we're treating. So at least in this country, mitral stenosis is much less common than mitral regurgitation. So in other countries where rheumatic heart disease is still a much more common occurrence, than mitral stenosis is a bigger problem. In the US, people get treated for strep infections. Rheumatic mitral disease is just not a very common problem. So that's number one. The transcatheter valve replacement technology, the way these valves work is they need something to latch onto. They need calcium in the annulus. That's why it works so well for aortic stenosis, because of all that calcium. So in a patient with mitral prolapse, mitral regurgitation, and a relatively normal, compliant, non-calcified mitral annulus, that same technology is not going to work. That valve has nothing to grab onto. It's just going to embolize. And so it's a radically different kind of structural problem. So all these companies are working on mitral interventional transcatheter solutions, and there's about 20 of them that are in early trials with various approaches to trying to do this. A lot of the early valves have failed, and it's usually because of embolization in the mitral position. It's really hard to get a transcatheter valve to sit there in the mitral, high pressure, dynamic environment. And the mitral annulus is not a fibrous circle the way the aortic is. It's all muscle, and it moves every time the heart contracts. That annulus moves, goes from circular to saddle shape back to circular every cardiac cycle. And so from an engineering standpoint, it's orders of magnitude more complex than the aortic valve.
But these patients with the MR, and the question is, you put a clip or the candidates. At this point, I think the best way would be to refer them to you guys to see are they a candidate or not.
Absolutely.
The problem that we have sometimes, who do we call?
Yeah.
I mean, for cardiomyopathy, we call Dr. Dragos, the cardiomyopathy team. For EP, I call, Dr. Steinberg.
Right.
For these kind of cases, we just call it transfer to center. I mean, it's hard to figure out where to send the patient to.
Sure. It's a great question, and that's part of why I'm here is to help kind of get that word out. And I've got a slide at the end, but we really consolidated our structural team into the surgeons that do structural heart intervention, the interventional cardiologists that do it, and then we have coordinators that we've now brought into the program to kind of direct traffic. And we actually have a heart valve clinic every Monday where it's the cardiologists and the surgeons. We sit next to each other in clinic and we see patients together, one after the other, and we talk about all these things. And we're having group discussions with the patients, with literally myself and one of the cardiologists in the room talking to the patient together, and we go through all these options that we're talking about here. And so I'll show you at the end, and I put some cards on the table. If anybody, my coordinators are on that card. If anybody has a patient,
we also have the transfer center phone number on the back of this card, so you can get a hold of CT surgery Dr. Glotzbach directly with his card.
And I think for elective referrals for this kind of a structural problem, the two coordinators on my little card that I put are the most efficient way to get to us. And either an email or a call to one of them, and they can get any heart valve or structural heart patient into our pipeline. And it doesn't really matter who's on call or which cardiologist, which surgeon, because we all talk about all these patients now. And we've come around on this as the way to do it. I think kind of model after the failure team that many heads are better than one. And so you don't have to worry about sending to one or the other, just send it to us and we'll sort it out internally. So thank you for that. Let's move on to tricuspid. I know we need to get to dinner here, but so the tricuspid valve, it's kind of the forgotten valve. For many years, people were not being aggressive with tricuspid valve disease. TR is such a dynamic fluid thing, as you all know, diuretics, RV status, all this comes into play. And so what do we do with the tricuspid valve? And really we're talking about secondary tricuspid regurgitation most commonly. There is primary tricuspid regurgitation, rheumatic disease, endocarditis, which I'm not really going into in this talk. All that can be primary disease with the tricuspid valve, if left untreated, can then cause RV dysfunction. By far the more common pathway is secondary tricuspid disease, either secondary to left-sided valve disease or RV dysfunction, or both. And so this tricuspid is often the kind of canary in the coal mine for a sick heart. You have RV dysfunction, you have left-sided valve disease, and the tricuspid regurgitation goes from mild to severe over the course of a weekend as a patient gets volume overloaded. And so this is something that's a little bit tricky to get your hands around if you're thinking about intervention on a tricuspid valve because it's so dynamic. And then most of the time when we treat the tricuspid valve surgically, it's in the setting of multi-valve disease. So it's a mitral regurgitation patient, and we add a tricuspid annuloplasty to it. And this is really the paradigm. It's RV failure causes tricuspid regurgitation, which then causes RV failure. And it's a circular kind of pathologic spiral. And sometimes you don't know where it started or where it ends, and that makes it difficult to know when to intervene on the valve. Should we just maximize RV therapies with diuretics, et cetera, and then the valve will get better, or does the valve need to be intervened upon? One other thing I wanted to throw out is that with tricuspid valve comes RV dysfunction, and with RV dysfunction comes liver disease, and it's often subclinical. And for this reason, isolated tricuspid repair is one of the highest mortality procedures that we do in cardiac surgery, and it's not because of the valve, it's because of the liver. These patients go into fulminant shock liver failure after surgery, and it's often subclinical. Their LFTs were normal, their INR was normal, they didn't have any hepatorenal syndrome, and so this is a space that we as surgeons are very wary when we see a patient with isolated tricuspid valve disease. We say, okay, that patient has a sick liver almost by definition. So the guidelines, any severe TR with symptoms should be repaired at the time of the other surgical procedure, which is often the mitral But then this moderate, what do you do with moderate TR? And I think this has been something that has been undertreated by surgeons historically, and we're now, as a field, starting to recognize this, that if a patient has moderate TR, especially with a dilated annulus defined as greater than 40 millimeters, that patient should get a tricuspid annuloplasty at the time of their mitral or the time of their aortic, less commonly. And this is data from Steve Bowling in Michigan showing excellent results from that approach. And basically, adding the tricuspid ring does not add morbidity or mortality to the mitral procedure that you're doing. And the freedom from TR long term is very good. Survival is very good. So this is a procedure that is absolutely, if someone is going for surgery and they have severe TR or even moderate TR with a dilated annulus, they should get a tricuspid annuloplasty. I think that is standard of care. This is kind of the future. This is a large registry, the TriValve registry, looking at tricuspid, transcatheter tricuspid therapies. And this is all very experimental and much less developed than the mitral space, and certainly less developed than TAVR. This is showing all these different approaches. So the people have used MITRACLIP on the tricuspid. The former device is kind of a spacer. It's a big kind of tube that goes in the middle of the tricuspid valve that the valve can then coapt around. The cardioband is an annuloplasty device, the TriCinch. These are all kind of various transcatheter technologies that are in various stages of development. This registry did show some improvement in heart failure and overall survival with these devices when they work. This at the bottom shows if a failed transcatheter therapy in the tricuspid did not change outcomes at all. So this is a very early field. We're starting to experiment with this a little bit in our practice. We've done a few MITRACLIPs. It's not something that's ready for prime time yet. So I think, in 2 or 3 years, we'll do this talk again, and maybe we'll have some more information on these transcatheter therapies. But because of all the physiologic variability that I talked about, this is a much even harder problem than the mitral to get our hands around what can we do transcatheter for the tricuspid valve. So I'm just going to end with the concept, and Dr. Christos brought it up, and it was a beautiful segue for me. This is our heart team. So this is interventional cardiologists, Dr. Chandar, Dr. Welt, Dr. Abraham, cardiothoracic surgery, so Dr. Selzman, myself, Dr. Sharma, McKellar. So we all work together. We see these patients in the clinic as a group. We decide what they're going to get. We talk to the patient about pros and cons of various approaches. If they go for surgery, then we do surgery. If they go for a transcatheter, we do the procedures together. All the TAVRs, all the transcatheter mitrals, all the MITRACLIPs, we all do them as a team. And then our cardiac anesthesia team is critical for the planning and procedural management of these patients, because a lot of it is so echo-dependent, echo-based. So Dr. Smith, Morgan, and Monzingo are kind of our leads in the anesthesia world. So these are all the physicians, and then we have our coordinators who are listed at the bottom there. On my card, Kelly and Aralia on my side, and then Mila and Matea are the 2 coordinators on the cardiology side. So we have a huge team of people, and we've really learned. We have a running list of patients that we talk about every week, twice a week actually, a Monday clinic and a Monday conference during our clinic, and then on Wednesday before we do most of our procedures, we have another conference where we go through the whole list of patients. We talk about the studies we have, the data we have, the clinical presentation, and we have all these management decisions are done as a group. And what we've found is that the patients are getting better care, at least in our practice. And so we're very committed to this approach, and we'd certainly be very interested and excited about talking with anybody about what we're doing or how we can help kind of reach out to your group here. If there's a way we can integrate things with what we do and what your patients need or what your practice is like, we'd be totally happy to work with you guys in any aspect of this care. And I think that this is the future. This is how these patients should be managed. It's not siloed, send them to one surgeon and they try to figure it out. This is all of us working together to provide better care. So